Good morning, everyone. Welcome, and thank you for joining today's webinar covering the California Rural Health Transformation Program, otherwise known as CalRHT for short. Today, we will be talking about the Accelerator Partners Grant Program. Folks are still joining, so we'll give them a few minutes here to continue to enter the room. Thank you for joining. All right, we'll go ahead and get started in just a moment. We see folks still trickling in, and then we'll begin today's conversation. Great to see the participation today. We're with well over 200 registrants and participants. So thank you for your interest in advancing rural health transformation across California. All right. Well, in the interest of time, we will begin today's conversation. Again, thank you for joining today's conversation around the California Rural Health Transformation Program, known as CalRHT for short. Today's purpose for the conversation is to learn more about the Accelerator Partners Grant Program. We're excited to see you here today and your interest in advancing rural health transformation across California. My name is Jennifer Hernandez. I am the director of the California Rural Health Transformation, and I'd like to introduce my colleague in just a moment to introduce himself. And again, the session today is really designed to help you understand what the Accelerator Partners Grant is all about and provide you context about the CalRHT program goals, and how to prepare your application. With that, I will invite my colleague, Dr. Tefera, to introduce himself, and then we'll review the agenda. Thank you.
Thank you, Jennifer. Good morning, everyone. Lumena Tefera, Chief Medical Officer and Deputy Director at the Department of Healthcare Access and Information. And very happy today to speak to you about the CalRHT Accelerator Partnership grant opportunity.
Thank you, Dr. Tefera. All right, a few housekeeping items. The recording will be issued in a few weeks. It does take a while to process and make sure it's accessible. We will also make public the slides from today's presentation. So focus on absorbing the content and asking your questions in the Q&A. Chat is disabled today, and so we encourage you to use the Q&A function to submit your question, and great appreciation to those of you that have pre-submitted your questions in advance. That will make today's conversation very fruitful. All right, so with housekeeping out of the way, let's move on to the agenda. Today's conversation, we will begin with an overview of the California Rural Health Transformation Program and how the Accelerator Partners Grant fits within this broader program. Then we'll give an overview of the Accelerator Partners Grant opportunity, including the program goals, metrics the program is aiming to further, and how to develop a strong application. Finally, we will cover important application dates, answer common questions that we've received, and remind you about additional resources that can help you prepare and submit your application. We'll make sure to leave time at the end to address some of the questions that can be asked live via the Q&A function, and point you to additional resources that can help support you after today's conversation. With that, I will turn it over to my colleague, Dr. Tefera.
Thanks so much. So the CalRHT program is a three-initiative vision that we have for transforming rural California. The transformative care model is the overarching program that is focused on developing rural collaboratives across the state with the downstream goal of developing regional rural collaborative care. The transformative care model is supported by the Workforce Development Initiative and the Technology and Tools Initiative. Uh, we hope and are working very hard to bring person-centered primary, maternal, and specialty care, enhancing behavioral care across rural California so Californians can receive care closer to home that's supported by sustainable workforce and modern technology and data to improve the care they get. As I said, uh, our focus this year will be expanding rural collaboratives and partnerships that will be elevating evidence-based care, deploying tools that work in low-resource settings, and invest in local readiness and the healthcare services of rural communities. Next slide, please. Uh, Delving more into the three initiatives, the transformative care model will be developing rural collaboratives to implement care models built on a foundation of a skilled workforce, leveraging effective technology to strengthen access, quality, and sustainability in rural health systems. Uh, our workforce development initiative will be striving to recruit, retain, relocate skilled and qualified clinical workforce to the rural communities that need them, but also in a thoughtful manner that is aware of the needs of the particular regions across the state. And our workforce initiative will be engaged in analysis of workforce needs across the state so we can be most effective in using our resources at CalRHT to support rural California. The Technology and Tools Initiative will be serving as a bridge to the workforce needs of rural Californians through grants and hands-on assistance to local entities. We want to increase opportunities for leveraging telehealth, e-consults, improve interoperability, enhance cyber security at participating sites, and also benefit communities to leverage patient-facing digital tools, including patient self-monitoring. As you see on the slide for budget year one, the Accelerator partnership program is funded at 39 million. Workforce recruitment and retention is budgeted at 54 million. And technology and tools in the first year will be focused on electronic health record modernization, and that will be budgeted at 11.6 million. Noting that for budget years two and onward for technology and tools, the opportunities for that grant program will include EHR modernization, but also some of the other items that I mentioned, including increasing telehealth and e-consult. Next slide, please. So as we seek applicants for the Accelerator Partnership Program, we want to kind of go over the high-arching objectives. Successful applicants will have initiatives that contribute to the transformative care model metrics in primary and maternal care, and we'll review those shortly. Successful applicants will share and describe innovative ideas that they think will be responsive to the needs of their rural community. Further, applicants will demonstrate the ability to partner and work together with other entities, other healthcare providers within their community to establish partnerships and demonstrate that through care coordination, they can address the identified care gaps with the solutions that they propose in the initiative. The goal, again, is to improve rural healthcare delivery, but furthermore, to improve rural healthcare delivery close to home so that patients in rural California can have the confidence that they're receiving high quality, evidence-based, evidence-informed care with clinicians that they know and trust, and that those clinicians will have the benefit of support from specialty centers that might not be in rural California, but are collaborating actively with those rural sites in formal relationships. Uh, Participants, entities, and rural collaboratives will not be working in independent silos, but will be sharing information with one another so that other sites can also learn from their enhancements and how they responded to their community's needs. And those actionable insights will be shared through community learning, and the CalRHT team and program will offer opportunities for statewide scaling of thoughtful, successful initiatives. Next slide, please. I briefly mentioned the transformative care model metrics for the program writ large. So Accelerator Partnership applicants will describe how their initiative to meet their community's needs touches on one of the core metrics. And for review, the metrics include hypertension control, diabetes control, improving screening for colorectal cancer, improving uncomplicated vaginal births after cesarean section rates, first trimester prenatal care, and leveraging telehealth virtual visits and e-consults to enhance the care of patients in rural communities. In addition to these key metrics, applicants can also submit initiative-specific metrics that they feel can capture performance relative to the novel engagements that they are recommending and intend to implement in their submission. So it's all these metrics across TCM, which we described in our project narrative, and each applicant can describe unique metrics that make the most sense for their program. Next slide, please. How will we evaluate applicants and their ideas for participation as an accelerator partner? It is important that applicants really embrace the idea of coming up with a unique solution to an identified problem in their community. Whether that's a matter of bringing in an existing care model that they've revised to make sense for their community needs, whether it's developing a new partnership structure with entities in their community working together to address the needs of their rural region, implementing technologies, developing new ways for service delivery. These are all the types of thoughtful engagements that we seek from applicants. Partnership, as we've said in webinars before, these are perennial challenging problems that we have in rural California. Access gaps, specialty gaps, distance for patients and their caregivers to traverse. We can only solve these challenges in partnership. So we think it's most effective that applicants for accelerator partnerships look and see who within their community is also working to address the same challenges and collaborate whenever possible so they can identify efficiencies of scale and also make the care treatment process easier for the patients and caregivers that we all intend to seek to support. CalRHT will be looking at operation capability of applicants. The challenge is always how can we most successfully implement an innovative concept? We think applicants who have previously demonstrated success in other work streams related to leadership in their community, whether it's from prior proposed projects, prior experience collaborating with regional providers, prior experience demonstrating their ability to scale, and demonstrable evidence that there's consistent and stable leadership within the entities participating as a rural collaborative to effectively implement their initiative. CalRHT will take all those into consideration when reviewing the application. And as I mentioned before, because the global aim of the transformative care model is elevating whole person care throughout rural California, besides the core metrics identified in the project narrative, we encourage applicants to develop and describe metrics specific to their initiative that we can include in tracking their performance and implementation. Next slide, please. And at this point, I'll be turning over back to CalRHT Director Jennifer Hernandez to continue the presentation.
Thank you, Dr. Tefera. Thank you for giving us a quick overview of the goals and priorities of the Accelerator Partners project. So now let's dig into a little bit more about the logistics. So as you all know, the application window for Accelerator Partners Budget Period 1 will close on August 14th at 3 p.m. If you submit your application after this deadline, your application will still be considered for the next funding opportunity in Budget Period 2. We are reviewing applications and selecting subrecipients on a rolling basis, so the earlier you submit your application, the better. CMS will be conducting a review of selected applicants in August and as we continue to evaluate applications. After CMS has approved the selected subrecipients, award notifications will be issued to applicants moving forward, which we can expect to happen by around September or so. Final grant agreements, including funding amounts awarded and grant requirements, will be negotiated and signed in September and October. All right, so just want to make sure that you all are aware of these timelines. Again, you can visit our website for updated information on this, but just really encourage you to be able to work towards submitting your application sooner rather than later. All right, so we will now go over a few example scenarios to answer some of the most commonly submitted questions that we've received to date. And then we will also have an open Q&A session at the end of the webinar. So one of the questions that we've been receiving is, what if I apply after the deadline? Maybe you're working with a group of partners and you just can't realistically submit an application. Well, first, we encourage you to apply as soon as possible if you already have an initiative or partnerships in place to receive funding from Budget Period 1. However, as you all know, the Rural Health Transformation Project is something that is intended to be funded over a series of 5 years. So there will be additional budget periods to seek funding from. Now, having said that, if you need more time to prepare a strong application and submit after the deadline of August 14th, your application will be considered for Budget Period 2 funding. The second question we often receive is, what if my organization is not focused on maternal or primary care? As you know, in our budget narrative and our program description, those are certainly critical aspects of our priority and focus for California. Now, if your organization is not focused on maternal or primary care, for example, maybe you're a dental provider, you still are eligible to apply if your program or initiative that you have planned contributes to one or more of the 6 TCM metrics that we highlighted earlier. So these metrics are also described in the grant guide and other resources on our website. Again, encourage you to revisit the budget narrative in the program description. The third question we often receive is what type of partnerships are accepted? As we know, no rural community is similar to another. Every community is unique. The same stands for partnerships, right? Partnerships really can range in their level of formality, and that's something we've constantly heard. However, it's more about demonstrating previous collaboration and having signed documentation describing the partnership that can really make an application stronger. So wherever you find yourselves, just be able to tell that story and show any documentation to reinforce it. If part of your proposal includes developing a partnership, that's okay. Perhaps you can share letters of interest or intent to support from partners. Those are certainly helpful to include in your application. It's more about the thoughtful partnerships that really will help impact your application positively and help in the scoring of an application. But again, if your organization does not have a partnership, you're still eligible to apply. A few reminders before we move forward into the Q&A portion of the conversation. So as you're preparing your application, please remember that we're here to work with you and we want to help you submit your best application. If you have any questions or need help throughout the process, please reach out and we will do our best to get back to you as soon as possible. Other reminders as you're preparing your application, it's definitely important to consider how your initiative can contribute to furthering at least one of the TCM metrics. Again, feel free to review the information on our website, budget narrative, and the program narrative. Thinking about how your initiative may apply to these metrics before you write your application will certainly be helpful in preparing and in developing your application. The more TCM metrics your initiative can contribute to may lead to a better application. Again, just reinforcing the idea that applications are rolling. So as soon as you're able to submit an application, please try to apply as early as possible. If you are unable to submit your application before the deadline, it will still be considered for the next budget period. And then lastly, please review the resources provided at CalRHT's website before preparing your application, especially the grant guide and the RFA. These are very helpful tools and documents to gather and prepare your application materials before you begin submitting through the portal. A few additional resources we want to call out that may be helpful in preparing your application. They can all be found on the HCAI's CalRHT webpage, where we will also be placing the recording of today's webinar along with the slides from today's presentation. Again, it does take us a few days to be able to adjust the recording to make sure that it has transcriptions and all the necessary requirements, but that along with the slides will be made available on our website. In addition, if you have any questions or support, please feel free to contact us. Any grant questions can be sent to info@calruralhealth.org. Again, info@calruralhealth.org, or you can feel free to call the toll-free number 1-888-CAL-RHTP. Again, 888-CAL-RHTP, and they'll be happy to answer any of the questions related to our funding opportunities. All right, we'll now be opening it up to Q&A, and I know a few have come in, but also want to make sure that we can address some of the questions that were pre-submitted. Really appreciate you taking the time to do that. But again, make sure you're writing down this email address, info@calruralhealth.org. And if your question was not answered in today's webinar, we'll please make sure to review the FAQs that we've posted on the website. And then if it's still not answered, you can feel free to send an email to info@calruralhealth.org, and then we'll respond to your question accordingly. So with that, I will stop the sharing and start looking at the questions that have come in advance and begin to answer these. And then again, feel free to submit your question live through the Q&A function, and we'll try to get through as many as possible. Thanks again for joining us, and we'll now begin the Q&A section of the conversation. All right, Dr. Tefera, would you like to kick us off with our first Q&A question?
Yes, let me see if I can. Has it already been put in the chat there, or should I reread it?
Yes, if you don't mind reading the chat question and then the response, please.
Okay, is the preferred emphasis maternity, or is it specifically first trimester of pregnancy, as is listed as the metric on the application? Thank you for the question. So, the focus of a rural collaborative um, uh, related to maternity care is the entire pregnancy. The metrics that we've devised really speak to what's the most thoughtful way to identify high risk birthers in community so they can receive the care they need as quickly as possible within the established rural collaborative. Among the concepts that we've shared publicly is using evidence-based and evidence-informed care models such as OB Nest. But we've also shared that it's important for specific applicants to think about the resources that they have available, including staffing, and also to be as inclusive as possible for all the needs of their birthers in community. So what we've described most recently is an approach that we're describing as CalNest, which is an evidence-informed approach that takes key components of OB Nest related to multiple screenings throughout the term, but also includes behavioral health screening for anxiety, depression, other behavioral health questions, so that each touch point with the birther, and that touch point can be from a community health worker, it can be from a visiting nurse, it can be from any host of clinical or non-clinical staff that the rural collaborative is able to engage to screen the pregnant person as early as possible, and when needed, offer telehealth referral as needed, or for the clinician who will see the patient in clinic or at the local hospital, offer e-consult services. So if they need further assistance from an expert obstetrician or family medicine physician with obstetric expertise, they can receive that in an efficient manner. So I hope that addresses your question, and happy to take the next one.
All right, I can kick us off with a second question as you look for another. The next question is it required that the provider have a physical address in a rural area? The provider does not have to have a physical address in a rural area. However, applicants may propose projects that serve rural areas and/or frontier and remote communities within California. Funds may be used to support activities consistent with CalRHT and CMS program requirements. Thank you for that question. We have been receiving similar questions, so appreciate that. Dr. Tefera, would you like to take another question?
Sure. Let's see. Uh, can organizations apply for Accelerator and one or more of the other grants? Yes. So We encourage applicants to apply first and foremost for opportunities that can support their initiative. The Accelerator Partnership offers the broadest set of options for rural entities to create collaboratives with other entities to support their community. However, it's quite possible that an applicant for an accelerator partnership to become a rural collaborative could also have workforce needs, and that same entity or group of partners can apply for a workforce initiative grant. And as I said, because the grant funding is separate, that would give that group of partners opportunities to gain retention, relocation, or recruitment funds separate from what they described in the Accelerator Partnership. That's also true for budget year one technology and tools that is focused on electronic health record augmentation, modernization. Those partners could apply for funds specific to EHR modernization that would certainly support whatever they're doing in their rural collaborative, but from a budget perspective is part of a different grant opportunity. If you have questions, if any applicant has questions regarding which grant opportunity makes most sense for them, you're also welcome to email us directly, and we have that email on our last slide, and we're happy to give you further guidance. And we can go on to the next question.
All right, and we spoke about, there's a question coming in. We addressed it, but maybe a little bit more context. So the question is, are MOUs or partnership agreements required to be finalized by the August 14th application deadline? We know that in many cases, these things do take time. So we recommend that there be at least an executed letter of intent or memorandum of understanding to undertake the partnership formation and negotiation, right? But full partnership terms don't need to be fully established at that point. If there is no letter of intent or MOU that exists, the applicant can still submit, but may not be as strong of an application as one that has an executed agreement already in place to collaborate with partners. So again, be able to at least offer some sort of supporting documents that sort of attribute to why you're in that particular situation and how you will be moving forward. All right, Dr. Tefera, next question.
Let's see. Will HCAI or CalRHT facilitate the establishment of any collaborations or consortia, for example, matching providers with vendors? So the application and the application portal ask that applicants identify a lead applicant and are able to include up to 5 partners on the application, but if you happen to have more than 5 partners, there's a means to describe more partners as well. The intent of the program is for the healthcare entity within the rural community to be leading the initiative, identifying the local care need that needs to be addressed, identifying and having developed the solution. For many cases, local entities will have already implemented and demonstrated proof of concept and success of an initiative that's addressing a local healthcare need. And what they're seeking to do is expand and scale their initiative, and also seeking for further expert support that CalRHT will be able to provide, not only from our in-house experts, but also through the rural health technical assistance that will be established by the fall. Regarding direct matching, CalRHT will not be directly matching applicants with vendors. However, if there are specific questions or areas of support, we're happy to respond to those on individual applicant basis. We think there's a lot of opportunity for shared learning, and among the work streams that the Rural Technical Assistance Center will engage in is establishing a forum for entities participating in CalRHT across the state to share learnings and experiences with one another that will hopefully inform how they select their partners and how they will implement their programs. I'll stop there for a moment.
All right. Another great question coming in the context of hub and spokes. Are spoke facilities required to submit an application on their own? The answer is no. Spokes do not have to submit a separate application as long as they're included in their lead organization's application. Fund distribution will be determined by the set accelerator partners in a single application, and then that application requests that the fund distribution be listed. So again, lead organization, spokes, all included in one application, no need for multiple. Thank you
And
for
the
that
only thing
question.
I'd add to that is that what we've been pivoting to describing the spokes and the hub and spokes as partners with the lead organization. So if you can envision the lead applicant, which will typically be a hospital in community working with multiple spoke partners, and those spoke partners can be clinics, they could be entities focused in helping with transportation, which is often a significant issue. They can be involved in pharmacy. They can be involved in care coordination. So all those spoke partners will be described by the lead entity, which will typically be a hub hospital in the community, and they will make up the role collaborative of the Accelerator partnership.
All
I
right,
think it's my turn again.
go for it.
Does submitting earlier improve the likelihood of funding, or all qualified applications evaluated equally? I think we're definitely comfortable saying that all qualified applications will be evaluated. The application process that we've described is a rolling application, which is to say, when we score and review applications, and we identify them as potential grantees, we'd like to make that decision as early as possible. We encourage applicants to submit as early as possible because, especially in this budget year one timeframe, the deadlines that have been set by Federal Health and Human Services and the Center for Medicare and Medicaid Services are quite tight. So the sooner we can make decisions, we think that's better for all applicants and future grantees to be successful in implementing their programs. That said, as long as you apply within the time frame that we've described, you will have a fair evaluation. And because budget year two is literally around the corner, we'll be starting in the late fall, come November. If we identify applicants that, because of limited funding, which is to say that, like everything in health policy, there will be trade-offs in who we can and cannot fund. If we identify applicants that we think have submissions that are really consistent with the ethos of the CalRHT program, we will work to find ways to make sure they're eligible for budget year two consideration.
All right, thank you. Here's another question. In an area with severe provider shortage, if applying for maternal care supports, would it be wiser to apply for Accelerator partners to create a provider pipeline or to workforce development or both? And so the answer to that is yes, feel free to apply for both. Both may not be approved and funded, but it may actually require both support. So feel free to submit your application. Yes, you're eligible to apply for multiple CalRHT grants. Thanks for the question.
Another one, can we modify the proposal metrics to fit proposed and population need, for example, pediatrics, or must we use the metrics in the RFA? This is a very good question, and it gives us an opportunity to speak about what we're seeking from applicants. Again, the transformative care model is designed to create local rural collaboratives that will be addressing community healthcare needs. Each rural collaborative in their initiative needs to identify um, a core metric of the transformative care model that's in our project narrative. Those core metrics should not be limiting. If your initiative requires or should have a unique project-specific metric, you can include that in your submission as part of your initiative, and that metric will also be tracked in addition to the core metric that you identify. Generally, most applicants will not find it difficult to describe how their metric can improve, for example, blood pressure management, diabetes care, and because so many rural communities are already leveraging telehealth and e-consult, and that's one of our cross-initiative metrics, they'll be able to also note that cross-initiative metric is their touch point to the core transformative care model metrics, in addition to the unique performance metrics that they submit. Let's see, do we have another one coming up?
All right. So we've talked quite a bit about budget year one and so on. So the question that came in is that they want confirmation about this is only budget year one of funding. And so the answer is yes. These dollars must be obligated by the fall of this year and spent by September 30th, 2027 under budget year one. So again, as we've mentioned earlier, the timelines move rather quickly. So want to make sure that as you're considering which program you're applying for, keep that in mind, that these dollars need to be spent down by September 30th of 2027. So do you have the capacity to spend down those dollars? That's critical information for you to consider.
The only thing I'll add to that is that we continue to be in conversation with CMS about what qualifies as spending down that money by end of September 2027, including whether establish contracts between grantees and other clearly described use of funds will meet the expectation of CMS audits. When we have final determination of what will be allowed as a permissible use of the funds by the end of the budget year, we'll be communicating to grantees so that they know all the different ways that they can successfully use the funds as required by CMS.
All right, here's another question that came in. Are there any barriers, problems to a spoke partner being included in multiple applications from different leading entities. So this is an important one. As long as projects are distinct and not overlapping or supplanting each other, then that should be fine. Again, coming directly from CMS, this funding has a lot of restrictions, and one of them is no supplanting. So as long as, again, it's a different scope, perhaps different geography, whatever the case may be, you should be fine.
I think that also speaks to another part of the uh, ethos for this program that we've mentioned a few times, which is partnership. We want local entities to partner as much as possible in ways that are thoughtful and effective to achieve the health outcomes for their community. It's perfectly conceivable that a rural clinic, federally health qualified center, or tribal health entity could contract or be part of a rural collaborative for one work stream, but that rural collaborative perhaps has a different partner for a separate work stream that doesn't make as much sense for that partner spoke. So if that partner spoke sees an opportunity to work with another rural collaborative, that's certainly possible. And as we've talked about before, the long-term vision of the local rural collaboratives is developing regional care collaboratives to address the care needs of a larger swath of rural California. So downstream, CalRHT will be working with the rural collaboratives to identify ways that they could work closer with other collaboratives focusing on different healthcare outcomes in rural California. And the outcome of that process is our aspiration to create regional care collaboratives. So again, this is year one. This is the launch of our program, and some of these very thoughtful questions that are being asked will the answers will evolve as we work in partnership with the local entities and learn together about what's the most effective way to be agile and responsive for the success of those initiatives.
All right, there's a few different questions about sort of strategically what makes for the best partnerships in terms of the collaboratives. So yes, an FQHC may participate. However, there's various partnerships that, depending on your particular community, might make sense. Any other thoughts you want to add, Dr. Tefera, around that question? Because again, a lot of it is really driven by the needs, maybe existing referral networks that already exist. Anything you'd like to add there?
I think that's really spot on. I think again, our aim is to really facilitate what historically have been informal relationships in rural communities between clinics, nearby hospitals to do the best they can to provide care. What the establishment of rural collaboratives will do is create a formal structure so that there is a thoughtful process for referrals and escalation of care so that clinicians in clinics, small hub hospitals, will have confidence they can get support from specialty, support from larger hub hospitals, and eventually tertiary or quaternary hospitals. I think the ethos of working together to find solutions for active clinical challenges and care gaps in community is shared, and all the partners who seek to do that will be excited to support. Um, I see another question, I think a very practical question about how grants will be funded to these future collaboratives. Uh, uh, will grant payments to the lead applicant be made in advance as reimbursements or after specific milestones are completed? Um, now, again, we need to be good stewards of public and federal funds. And as we described in the grant guide, their expectations of tracking and managing the grant funds. That said, we are very much aware that one of the core challenges in addressing care gaps in rural communities is not having sufficient financial resources to implement the homegrown ideas that leaders uh, um, uh, want to implement for the benefit of their community. So, and this is something that you should describe clearly in your application as far as what you seek. But we understand there will be a need for a portion of the grant to be an upfront payment to help the recipient start and build up the team, acquire the resources, and engage in the programmatic activities to implement their initiative. And then there will also be milestone funding so that we as CalRHT can track how successful the grantee is in administering and implementing the initiative that they have described. And as they achieve those milestones, as they demonstrate consistent performance, they will receive more funding. The number of milestones and the proportion of the funding that will be upfront versus milestone based will be specific to the initiative because each initiative will have different financial needs. And we're happy to work with grantees to make sure that the organization of the funding will be such to allow them to be most successful. And we see that that conversation is something that will be done in the post-award period once we identify grantees and we'll need to we'll have the opportunity to really closely look at the specific details of their budget and their particular needs. This is also described in our grant guide, which is published with even more detailed information than I just shared.
Thank you. All right. One of the other questions we received is there a population of focus or are all populations in scope? So again, broadly speaking, access to primary care, maternal health, et cetera, those are all key components of the priorities for CalRHT. However, as we called out earlier, there's a series of metrics. So as long as you can connect the work you're doing to those metrics, that is really one of the best way to look at it. Just calling out that in the resources tab, you will have additional information that you can lean on for more resources. So the budget narrative, the website, all of that is available there to help give you additional information on how to best frame your connect your work to the priority areas of CalRHT.
Another question that's come up, can a federally qualified healthcare center be a hub partner? Now, as described in our project narrative, the purpose of the rural collaboratives and the leveraging the hub and spoke approach is to offer higher degrees of support for clinicians in community and to decrease barriers to care for patients in community. Generally, clinic care challenges are or include access to efficient specialty referrals, both for the physicians and clinicians in those clinics, and also barriers to those same clinicians for the patients in community. So the FQHC will typically be a partner to a community hospital, a rural community hospital, a critical access hospital, or a medium-sized hub hospital in community, because that larger site will offer specialty access for whatever service line that particular clinic needs to enhance the care of the patient. The other opportunity for partner spokes like federally qualified healthcare centers, rural health clinics, and tribal health entities is to increase the capacity for telehealth in rural communities. How will they be able to increase capacity? Many sites already have telehealth access, but using CalRHT funds, they can increase the number of telehealth service lines available. This may include increasing private telehealth booths where patients can come and have their telehealth visit with the specialists that they need. The clinics, whether FQHC or other, can hire telehealth coordinators so that they can maximize the use of telehealth at their site to make sure that the technologies purchased through the CalRHT program, whether it's software for telehealth, hardware devices, can be used as much as possible, scheduled efficiently, so that throughout the working clinical day, patients can see as many specialists as possible with those telehealth resources. Again, in the background of this regarding telehealth in rural communities is that broadband internet infrastructure can be incredibly varied. Some places will have none, some places will have better. Most places it's not consistent. So because there are these types of grant use for something to the extent of internet or other local infrastructure is an impermissible use. Our approach is to increase the capacity by supporting local clinics to increase their ability to provide reliable telehealth services. And because their site has reliable broadband and technologies, we think that's the most effective way to reach the most members of rural communities as possible.
All right, we have another question. And for those of you that have not started your application in the portal, just this will be helpful insight. So the question is, for narrative sections with a 500-word limit, and there are various word limits throughout the application, if a response is slightly over, example 510 words, will it be accepted, truncated, or negatively affect the application? We certainly would encourage you to reframe your response to stay within the limit. And again, be mindful of the word limits that exist for various sections. So again, helpful to maybe if you're in a Word doc and then cut and paste, just to make sure that you're within the word limit. Great question.
Another question that's previously come up is opportunities for partnerships in community, especially with pharmacies and other healthcare adjacent providers, including emergency medical services. So the vision for collaboratives is really focused on providing care to communities in the most efficient way possible. As we all know from whether our personal experiences or experiences through friends and family, pharmacies are a frequent touch point for care services. So if there are collaboratives that seek to enhance um, uh, care collaboration, medication reconciliation by including their local pharmacy in their collaborative as a partner, that is certainly welcome. It's also true that in rural communities, emergency medical service providers can be a unique touch point, seeing patients in their homes and offering an opportunity for screening or other engagement. So if you have ideas how to leverage these touch points closest to patients in their community, those ideas are also welcome as partners for the rural collaboratives.
Thank you. We're receiving quite a few questions asking about future webinars or the timing of other grant opportunities. Again, for budget year one programs that we are launching, we would encourage you to sign up for the listserv. That is the primary method that we're sharing information on upcoming awards that become available. We do anticipate in releasing the workforce development recruitment and retention program in the next few weeks. So again, visit the website frequently and make sure you're signed up for the listserv. And we will be doing similar webinars for other RFAs and grant opportunities.
Another question that's been brought up before is that in the original project narrative, it wasn't clear if there are opportunities for elevating geriatric care and oral health care. And we like to note that the CalRHT program is a whole person focused group of initiatives. And the transformative care model is really about identifying as many ways as possible to enhance rural healthcare. So if you have ideas that touch on geriatric care or opportunities to include oral health in your rural collaborative, those ideas are welcome as well.
All right. Some of these appear to be overlapping. So let's see. We received them in is an accelerator partnership necessary to get funding? I think we talked about this earlier. Again, partnerships will look a little bit different. So it's about telling us sort of where you are in the process, being able to share any information, whether it's a letter of intent, support letters, MOUs, regardless of where you are, just some documentation to support and sort of telling the story of what your goals are with that particular partnership. So hopefully that can help.
Regarding the importance of memorandum of understanding and other documentation of partnership, certainly in the review of applications, it will be really important for applicants to demonstrate that they have willing and engaged partners and have at least an outline of the governance of how the lead entity, which often would be a hub hospital, will be working with multiple partner spokes, whether they're clinics or other healthcare providing entities. The ability of the lead applicant to share clear description, understanding from the partners that they are committed to working together, that they're committed to a governance structure, that they're committed to focusing on the described healthcare outcome and improving on the gap of care. All that will be a part of the assessment when we score applications for likelihood to be successful grantees that can implement their initiative.
All right, trying to scroll through these. Again, some of them we've already addressed. Dr. Tefera, I think this one would be helpful for you to address. Are applicants able to develop an innovative model in lieu of using ECHO or OB-NEST?
Sure. As I touched on before, uh, we want to elevate evidence based initiatives as much as possible. But there is a great deal of opportunity to to allowing for evidence-informed models to be incorporated in initiatives. And while it might seem nuanced, the difference between evidence-based and evidence-informed, it's really practical at the hospital or clinic level. For example, OB-NEST, excuse me, OB-NEST, which is commonly described as a strong maternal model, has been used nationally, has a specific thresholds for age, 18 and over, and was implemented with only English-speaking participants. As everyone on the call knows, as the largest state with nearly 40 million across a large land swath, we also have the benefit of a multilingual, multicultural, multi-ethnic California. So we fully expect that applicants who are working on rural maternal collaboratives will make sure that their initiative will be open to non-English speakers. And depending on their catchment area, it may make sense to include adolescent birthers as those that they screen. What we want to offer as many opportunities for evidence-based and evidence-informed care models for applicants to consider, but we don't want to be prescriptive. We also know that depending on the site, the staffing challenges may preclude exact implementation of a model as it was conceived. But if an applicant is able to describe a revised approach that will achieve the same results to increase healthcare screening, whether it's for birthers in a maternity model or for management of chronic conditions like hypertension and diabetes. We are open to receiving those evidence-informed approaches and understand that we will only be successful if we're agile and as inclusive as possible of ideas to bridge the gaps in rural healthcare.
All right, thank you. We're just under 20 minutes left before we conclude. So I want to get through a few more of these. Can the focus be only on primary care, if not maternity? Yes, again, remember, as long as you can connect it to one of the metrics, then you should be fine. Another quick question. Let's see. Can a local health district, public health clinic apply? The answer is yes. Certainly encourage you to apply as part of Accelerator Partners.
The only thing I'll expand on that is that the nature of primary care services is that it really touches on everything related to the management of a patient in any community, not just a rural community. Even if there is an applicant interested in expanding access to gastroenterology services or orthopedic services or rheumatology services, the successful applicant will describe how that specialty service access that they wish to bring to their community is connected to the ongoing primary care that patient receives. Because the ongoing primary care that patient receives will ultimately be managing and following up the recommendations that the specialist provides, and will also be continuing a direct conversation between the primary care clinician and the specialist clinician for the benefit of the patient. So as many primary care clinicians, and I'm sure there are many on this call, will attest to, it is foundational to whole person care, so that even when we're speaking about a maternity rural collaborative, specialty rural collaborative, enhancing behavioral health, all of those will have touch points in primary care, and the applicant should clearly describe how their initiative trying to enhance access to one area of specialty care is linked to the ongoing primary care of that patient.
Thank you. All right. There's another question around indirect costs. As you all know, this is funded by CMS, and so the indirect cost is limited to 10% for this particular program. And we momentarily will be dropping in the notice of funding opportunity, the NOFO, which is also available on our CalRHT website in the resources tab. So again, further information on allowable use of funds, but again, for this particular program, it is indirect cost is limited to 10%.
Another question was previously raised, but slightly nuanced, related to the Rural Technical Assistance Center. Again, we are looking forward to launching the Rural Technical Assistance Center in the fall. That center will help grantees problem solve in the implementation and their initiative. That center will also offer support to metric reporting, which is critical for the success of the grantee, and is also required from CalRHT by CMS and federal HHS. There will be a means to contact the Rural Technical Assistance Center by any grantee with a question related to their initiative, and based on how that question, the details of that question, the Rural Technical Assistance Center will connect the grantee to the correct subject matter expert and team to help address that. Or if it's related to fund management related to metric reporting, will directly offer that assistance. We are hoping that many of these questions will be able to answer and support remotely, whether it's by telephone, video conference, but we also recognize that there will be certain initiatives and challenges in implementation that will require in-person and hands-on engagement. So part of our planning is to, depending on the need and when identified, to be able to go on-site to work with the local leaders of the Rural Collaborative and problem solve together how to make that initiative most successful. So we look forward to establishing the Rural Technical Assistance Center, and we think it will be a tremendous resource for grantees. And for future budget years, we aspire to expand the support for applicants who have questions to strengthen their application for new ideas to come to CalRHT.
All right, thank you. Another question, what is the indirect fee for the application, and is there a max for the lead applicant? So as we said earlier, the indirect cost limit is 10%. And then in terms of sort of distributions for participants and an accelerator partners, again, a lot of that will really be determined by the needs and the way that you structure your proposal. So as long as it can be reinforced with a narrative that describes the why behind your decisions, that's really what we're looking for. There is no predetermined sort of distribution.
Somewhat related to that, applicants have asked about in describing multiple initiatives. First, whether should they describe multiple initiatives as a single applicant, and if they describe multiple initiatives for their role collaborative, how best to present it. And what we've noted again is that there's a budget constraint. As you saw, 39 million is our budget year one limit. And there is a focus to be as aligned as possible to transformative care model. So if you are applying as a role collaborative with partners and have multiple ideas, it's very helpful for us that you describe your initiative and also describe your budget in modules where we can see clearly that, initiative one from this collaborative tracks easily to the specific budget lines. Initiative two in this submission tracks specifically to specific budget lines in the budget in the submitted budget proposal, so that if for whatever reason, because of budget constraints in budget year one, we're able to fund all of your proposal, great. But if we're able to fund one out of the three modules that you submit, it'll be easier to manage the application if you present it in a way that those second, third, fourth proposals can be separated from the primary lead proposal.
All right. Another question. When funded clinical partners apply and let's say they receive transformative care model resources, does HCAI expect them to be treated as subrecipients or contractors? Great question. According to CMS, we will be treating those funded under the Accelerator Partners Program as subrecipients. All right. And yes, confirming that the Accelerator partners, this is for round one funding. And then if a partnership is not required, is funding decision weighed in favor of partnerships being in place? As we mentioned earlier, yes, being able to show the level of partnerships is certainly favorable for a stronger application. Doesn't preclude you from applying. However, partnership is certainly favorable. Let's see, another question around, can we apply for multiple programs? So Accelerator program and others that will become available. Yes. Again, the answer, you can apply for multiple grants under CalRHT. Just keep in mind that the money does have to be spent by September 30th of 2027 for awards received in this first budget year.
As we're coming up on time, Jennifer, are you able to pull up the question slide? I just want to make sure people see our info@calruralhealth.org email, where we're encouraging folks to ask specific grant questions.
All right, hopefully that's displaying okay.
This looks great. So, we've tried to, answer as many questions as possible during the webinar today. Of course, you'll think of more as you develop your initiatives, which is why we have established this email that will give you the opportunity to get a response from our broader CalRHT team, depending on your inquiry. So please don't hesitate to reach out. And going back to kind of where we started as far as um, uh, the vision of the program, just calling out again that we aspire to create this transformative care model that's supported by workforce initiatives to provide retention, relocation, recruitment for uh, qualified and skilled clinicians to rural communities. While we bring those clinicians to rural communities, we want to leverage technology and tools so that we can elevate telehealth, e-consult to bring care to patients in communities so they can receive that care without the challenges of distance and time and costs related to transport. And those technologies and tools can also improve the cyber security, data sharing, and revenue cycle of local entities so that they become stronger and more sustainable entities. It's a lot that we're trying to do. We are excited and happy to be ambitious and happy to have your partnership in establishing programs across the state that will build towards this a larger vision. And I'll turn it over to our CalRHT director for closing remarks.
Thank you, Dr. Tefera. Okay, just a reminder, make sure you're reviewing the Accelerator Partners Grant Guide, the RFA. There's a series of FAQs that are available for you. Last resort, if you have any further questions, as Dr. Tefera said, feel free to email us. Also, feel free to call the helpline at 888-CAL-RHTP. We look forward to working with you in improving access to healthy rural communities. And this is not the last of the webinars. More to come. Encourage you to sign up for the listserv if you haven't already. Again, make sure to look at the resources at the bottom right as you exit the webinar, just to make sure that you're signed up and have an ability to receive future notices. Again, thank you so much for joining today's conversation. Look forward for ongoing communication and look forward to reviewing your application. Thanks so much for joining today. And again, reminder, these documents will be posted on our website as soon as possible, the recording along with the slides. Thanks again for joining us. Have a great day.